we see the dad as the bear, but you also recognize that that's just intergenerational transmission right there, and it is really treatment of all the parties involved that are necessary to break that intergenerational cycle. And that dad did end up saying to his daughter, I know that daddy was really scary and really hurtful, and I'm really sorry, as part of a therapeutic process.
Okay, good afternoon, everyone. My name is Sondra Leggi Brandon. I'm the Vice President of Behavioral Health and Medicine. Thank you for being here today. Thank you for allowing us to sponsor this event. We have a guest speaker that we're so delighted is able to join us today. So Dr. Nadine-Burke Harris is an award-winning physician, researcher, and public health leader who has spent her career on the front lines of some of our world's most pressing public health challenges. As California's first ever Surgeon General, she helped guide the state's COVID response to achieve the lowest cumulative mortality of any large U.S. state. And amid the throes of the COVID pandemic, Dr. Burke Harris successfully launched a first-in-the-nation statewide effort that has trained more than 40,000 primary care providers on how to screen for adverse childhood experiences or cases and respond with trauma-informed care. Dr. Burke Harris's career has been dedicated to serving vulnerable communities and combating the root causes of health disparities. After completing her MPH at Harvard and the residency at Stanford, she founded a clinic in one of San Francisco's most underserved communities, Bayview 100th Point. It was there that Dr. Burke Harris identified ACEs as a major risk factor affecting the health of her patients and applied research from the CDC and Kaiser Permanente to develop a novel clinical screening protocol. Her work has been profiled in best-selling books and award-winning films, as well as on BBC, NPR, CNN, Fox News, USA Today, and the New York Times. Dr. Burke Harris's TED Talk, How Childhood Trauma Affects Healthcare Across a Lifetime, has been viewed more than 12 million times. I'm one of those people, by the way. And her book, The Deepest Well, The Healing, the Long-Term Effects of Childhood Adversity, was called indispensable by the New York Times. So please join me in welcoming Dr. Nadine-Burke Harris, please.
Thank you so much. It's such a privilege and an honor to be able to speak with you all today. And I'm really excited to talk a bit about transforming our systems to improve outcomes for this generation. So just a quick show of hands, how many folks are familiar with the ACE research? Okay, oh, just about everybody. And how about the toxic stress response? Fantastic. So I'll start by just doing a quick overview and then really talk about how we can take this science to think about improving our clinical care, our quality of care, and then also our systems in which this care is delivered. So this work for me began when I finished my residency and started a clinic in a very underserved neighborhood of San Francisco called Bayview 100th Point. And as a community pediatrician, I was being referred a lot of kids for ADHD, attention deficit hyperactivity disorder. And these referrals were coming to me from teachers and nurses and community members who were saying, can you please see Bobby? He can't sit still in class. He's hitting the kid next to him. Please, Dr. Burke, this was before I got married, he's got ADHD. Can you please put him on some Ritalin? And when I did a thorough history and physical, for a lot of the kids I was seeing, I actually couldn't quite make that diagnosis because although my patients were exhibiting many of the same symptoms, at the bottom of the Diagnostic and Statistical Manual, the DSM, it said, and these symptoms are not caused by any other mental health disorder. And so for me, looking at that, I was like, well, what if it's not a mental health disorder per se? Because what I was noticing was that I was seeing the highest rate of these conditions in my patients who, when I did the history part of the history and physical, I was learning that they were exposed to a parent who had an untreated mental health disorder or substance dependence, or who were witnessing violence at home or in the community. And it turned out it wasn't just their behavior. I was noticing the highest rates of other disorders like autoimmune disorder, asthma in my kids who had significant exposures to adversity, right? So I'll never forget, I had one patient, as I was asking about her asthma triggers after giving 2 rounds of oral steroids, and asking her mom again, what is it we could be missing? Is there anything you notice that might trigger her asthma? I'll never forget what this mom said to me. She said, Doctora, I noticed that my daughter's asthma tends to act up every time her dad punches a hole in the wall, right? So for me, that led me to look at how exposures to adversity affect children's developing brains and bodies. And that's what led me to the landmark ACE study, which I know many of you are familiar with, published in '98, conducted by the CDC and Kaiser Permanente, in which they asked 17,500 adults about 10 categories of adverse childhood experiences, including physical, emotional, or sexual abuse, physical or emotional neglect, or growing up in a household where a caregiver was experiencing mental health disorder, intimate partner violence, parental separation and divorce, incarceration, or substance misuse or dependence. And of course, the key findings from this study were 2 really breakthrough findings. One was that ACEs are incredibly common, right? So 2/3 of folks had experienced at least one, and 1 in 8 folks in that original study population had experienced 4 or more. Of note, that original study population was 70% Caucasian, 70% college educated. So we recognize that ACEs happen in all communities, but we also see that now that the CDC collects ACE data in all 50 states through the behavioral risk factor surveillance system, we see that ACEs, exposure to ACEs is unequally distributed, and that vulnerable communities and communities of color, our LGBTQ communities, experience higher rates of ACEs. Here in Hawaii, we see that Native Hawaiians experience higher rates of ACEs as compared to whites. So the second finding was that there was this dose-response relationship between adverse childhood experiences and a whole range of behavioral, mental, and medical outcomes over the lifetime, right? So when we say dose-response relationship, we mean the greater number of ACE categories that an individual was exposed to, the greater their risk for adverse physical, behavioral, and mental health outcomes. So here we see high-risk drinking by ACE score. Here, early sexual initiation, that same dose-response relationship. When we look at teen pregnancy, we see the same relationship. When we look at cumulative ACEs and mental health, we see that same dose-response relationship. When we look at ACE score and substance use, we see a substance use and dependence. We see that same dose-response relationship. When we look at homelessness, again, that same dose-response relationship. And for many folks, that was kind of maybe common wisdom. I think many of us recognize that if you have a rough childhood, you may be more likely to engage in high-risk behavior. What was a surprise to many folks was that that same dose-response relationship existed between ACEs and 9 out of 10 of the leading causes of death in the United States, including heart disease, cancer, stroke, Alzheimer's, right? And what's fascinating is that when we look at the association between ACEs and heart disease, the number 1 killer in the United States, an individual with 4 more ACEs has double the risk of ischemic heart disease as someone with 0 ACEs. For someone with 7 or more ACEs, those odds go up to 3.5 times. They're 3.5 times as likely to have heart disease as compared to someone with 0 ACEs. And when we do the logistic regression analysis to remove the effect of health-damaging behavior, for someone who doesn't drink, doesn't smoke, isn't sedentary, doesn't engage in risk factors for cardiovascular disease, that only attenuates about 50% of the risk, right? So understanding, well, why would someone who doesn't engage in any high-risk behavior still have increased risk for cardiovascular disease if they have high ACEs? And to understand that, we have to look at the biology of adversity, right? We know that it has to do with our brain and body's biological stress response, our fight or flight response. And it works a little something like this, right? So imagine you're walking in a forest and you see this guy, right? What happens? What happens in our brains and bodies? Well, our amygdala, right, sounds the alarm and activates the fight or flight response, turns on the sympathoadrenal medullary axis to get adrenaline, and the hypothalamic pituitary adrenal axis to produce cortisol, right? So we have increased levels of adrenaline and cortisol, and so our hearts start to pound. Our pupils dilate, our airways open up. We increase our blood pressure, right, to drive more blood to our large muscle groups for running and jumping. We increase our blood sugar, right, to provide more nutrients to our muscles to be able to contract and provide energy, right? We shut blood away from that itty bitty muscle that holds our bladder closed, so you may pee your pants, but that's okay. There's no judgment there, right? And so we are ready to either fight the bear or run from the bear. And this is genius, right? But if you were to think about it, fighting a bear wouldn't seem like a good idea, would it? No, let's look at him. He's big, he's got teeth, he's got claws. And that's why the amygdala actually sends projections to the prefrontal cortex, right? Our seat of executive functioning, where we have judgment and impulse control. And it down-regulates the prefrontal cortex, right? It turns it way, way down. Because the last thing you want, if you're in a forest and there's a bear, is some impulse control get in the way of survival. And instead, right, what it does is it turns up the noradrenergic nucleus of the locus ceruleus, are within the brain stress response activation system, or as I like to call it, the part of the brain responsible for, I don't know karate, but I do know crazy, right? This is, gets us amped up. Now, the less obvious thing that happens when we activate our stress response is that it also activates the immune response. Because if that bear gets his claws into you, you want your immune system to be primed to bring inflammation to stabilize that wound so that you can either live long enough to either beat that bear or get away. This is brilliant. It was evolved over millennia to save our lives from a moral threat. But the problem is what happens when that bear comes home every night. And this biological process is activated over and over and over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Now, we know that children are especially sensitive to the repeated activation of the physiologic stress response because their brains and bodies are just developing. So high doses of adversity in childhood affects the developmental trajectory of children's brains, immune systems, hormonal systems, and even the way DNA is read and transcribed. And one of the things that we see is loss of the normal feedback inhibition of the HPA axis and the SAM axis. So we see prolonged activation of our stress response systems, that can disrupt the development of brain architecture and other organ systems and increase the risk for stress-related disease and cognitive impairment well into the adult years, right? So this is what is now known as the toxic stress response. And we now understand the impacts of the toxic stress response in terms of chronic dysregulation of our autonomic nervous system, right? Altered reactivity and size of the amygdala, inhibition of the prefrontal cortex, hippocampal toxicity, alteration of the VTA and reward processing. So you all remember I'm going to have to go back to neurology, right? The VTA, the ventral tegmental area that works in partnership with the nucleus accumbens. This is the pleasure and reward center of the brain. And this is the area where cocaine, heroin, alcohol, tobacco, high sugar, high fat foods, right? All of the substances of dependence act on the pleasure and reward center. And one of the things that we see is that this area of the brain becomes dysregulated with high levels of childhood adversity. And that's actually part of the reason. So when folks say, oh yeah, of course, you have a rough childhood, you're more likely to drink and smoke, it actually turns out that the experience of adversity in childhood leads to changes in the reward center of the brain that increases the risk of engaging in high-risk behavior and increases the risk for substance dependence. And one of the things that we also see and can now measure, right, is that the toxic stress response, there's actually vertical transmission of toxic stress biology. So, for example, when we look at moms who have experienced high doses of adversity, we can now see that in the cord blood of their newborn infants, right, derangements in neuroendocrine, immune, and genetic regulatory signaling, right? That can be measured as early as in cord blood. So we see that one of the things when we see, as a clinician, when I would see a child with significant ACEs, if I'm seeing a 7-year-old with 4 ACEs, right? More often than not, and in fact, almost uniformly, when you look at the parent and understand their history, you recognize that there's an extremely strong pattern of intergenerational transmission. And so we recognize that treatment of toxic stress in adults is important not only to improve outcomes in adults, but also to prevent the vertical transmission. Because one of the things that we understand when we now recognize this science, right, is that ACEs are not destiny. And with early detection and early intervention, we can transform health outcomes. So I talked about the toxic stress response as the chronic dysregulation of the physiologic stress response and the subsequent neuroendocrine, immune, and genetic regulatory disruption. But we also know that a normal and healthily functioning stress response is what we call the positive stress response. The stress response gets activated, it reaches a certain point, you have to release of adrenaline, cortisol, and all the stress hormones, and then once it reaches a certain point, it shuts itself off by itself. Now, between the positive stress response, where the physiologic stress response shuts itself off by itself, and the toxic stress response is what we call the tolerable stress response, which is with more severe or intensive stressors. But this piece was so important that we put a little gold box around it, right? It says homeostasis recovers through the buffering effects of a caring adult or other interventions. And that's really critical, right? Because the science is now showing us, right, that just as we are able to measure the neuroendocrine, immune, and genetic regulatory disruption that goes along with adversity, we're also now better able to measure than we ever have before the effect of interventions that specifically target regulating the stress response. So the most well-known of these are safe, stable, and nurturing relationships and environments, right? High-quality, nurturing caregiving. In addition, things like time in nature is associated with helping to regulate the decreased sympathetic activation and increased parasympathetic activation. Things like mindfulness, such as meditation, is associated with regulating cortisol levels and decreasing immune activation, decreased interferon gamma and natural killer cell production of IL-10, and increased T cell production of interleukin-4, which is an anti-inflammatory marker. We also see things like healthy sleep is really important for helping to regulate the physiologic stress response. And certain mental health interventions are associated with, again, all of these interventions here. And in fact, this is a lot of words. The point is we're beginning to much better understand the science that specifically target the toxic stress response. And we recognize that sleep, exercise, certain forms of nutrition, mindfulness, certain mental health interventions, and access to nature are associated with reduced stress hormone activation, reduced inflammation, and enhancement of neuroplasticity. In addition, some of these interventions are also associated with normalization of epigenetic programming, right? So that's pretty exciting. And when we look at this, some of these things that we can measure physiologically, but it's also important, one of the things that we did in the California Surgeon General's office when we wrote the Surgeon General's report on ACEs, toxic stress, and health, was really look and said, okay, we recognize that there may be clinical examples of these interventions, but are we seeing improvement on a population level? And we can see there was some excellent research that was done in the UK that showed, again, this dose-response relationship between ACEs and adverse health outcomes. This is specifically looking at health-harming behaviors and lower mental well-being, but they also looked at certain infectious and inflammatory diseases as well, and found that individuals who received high doses of buffering interventions had a dramatic reduction in the prevalence of these adverse outcomes. So we do see that on the population level as well, that these buffering interventions actually help to regulate the stress response and reduce the adverse outcomes. So when we understand that, right, that's really powerful in terms of we recognize, again, that with early detection and early intervention, we can improve outcomes. And, you know, there's oftentimes this argument among those of us who are in the helping professions, which is more important? Shouldn't we be preventing ACEs from happening in the first place, or shouldn't we improve our treatment? And we recognize that from a public health standpoint, all of these things are necessary. So one of the key findings of the Surgeon General's report is that we need to do prevention at all levels. Primary prevention, preventing ACEs from happening to begin with. Secondary prevention, early detection so that we can do early intervention when it's more likely to be effective. And then also tertiary prevention, which is effective and evidence-based treatment. And in California, we launched an initiative called the ACEs Aware Initiative, where we've trained over 40,000 healthcare providers across disciplines to screen for ACEs, and we reimburse them for screening, which is also really important, and then how to respond with evidence-based trauma-informed care. So here we see the clinical algorithm from the ACEs Aware website on how to screen us for ACEs, and this is both in pediatrics and in adult medicine, because we recognize that treating toxic stress in adults is critical both for improving those outcomes and reducing the vertical transmission. And so when we look at it, a screening involves assessing for ACEs, part one, the ACE screen, assessing for ACE-associated health outcomes, and then using that to determine whether a patient is at low risk of a toxic stress physiology, intermediate risk, or high risk, right? So here's a quick example of what this looks like clinically. This is a real patient, a 2-year, 9-month female who presented for her well child exam. She was small, but otherwise well and no other complaints. She had an unremarkable birth history and developmental history. Her pediatrician had recommended Pediasure, right, which is the #1 treatment for failure to thrive. But according to mom, it didn't seem to help. And so what we did was we did the ACE screen. This is the PEARLS screen that was developed from the randomized controlled trial, the PEARLS trial that did the validation of the screening tool. And you'll see here are the ACE categories. In the PEARLS tool, we actually, in the randomized controlled trial, looked at an identified screen, whether or not patients report each ACE that they experienced, or a de-identified screen where they just put the number. We found that the de-identified screen was associated with easier clinical flow, and then also it's on average, a slightly higher reporting rate for ACEs. And then part 2 of the PEARL screen includes other things that are potential risk factors for toxic stress, things like discrimination, etc. But weren't included in the original ACEs, so we don't necessarily have the same odds ratio for risk for things like diabetes and ischemic heart disease. And then we assess for ACE-associated health conditions. We recognize that failure to thrive is among the list of ACE-associated health conditions. And so when we look at the evaluation of this patient, we see that her physical exam and developmental screen was normal. Her ACE score was a 7 plus 0, 7 on the traditional ACEs, 0 of the additional categories. So this was a 2-year, 9-month female with failure to thrive at high risk of a toxic stress physiology. And so when we look at what the recommendation says for high-risk patients, provide patient education about toxic stress, its likely role in the patient's health condition and buffering, assess for protective factors, and jointly formulate a treatment plan. So when we think about the evidence-based buffering interventions, in this case, we're going to use a mental health intervention, child-parent psychotherapy. And I'll talk more about that in just a second. But we recognize that a clinical response to ACEs and toxic stress includes applying principles of trauma-informed care, including establishing trust, safety, and collaborative decision-making. And then the second piece is the key part, supplementing usual care for ACE-associated health conditions by providing patient education on toxic stress and offering strategies to regulate the stress response. So in this case, it involved patient education, usual care, which was Pediasure, right? 1 can twice a day, and then referral to child-parent psychotherapy, which you might not typically do for failure to thrive. But in this case, because the patient is at high risk for toxic stress, we know that child-parent psychotherapy is actually an evidence-based intervention to help regulate cortisol levels and also reduce epigenetic programming. And then we are doing regular follow-up to assess the clinical efficacy, right? So in this case, is explaining to mom, I think that because of what your daughter experienced, her body may be making more stress hormones than it should, and this may be what's affecting her growth. I want to refer you to a specialist that can help you understand how to support her. And we also know a healthy caregiver is the most important ingredient for healthy children. So an important part of helping your daughter heal involves managing your own stress level and practicing self-care. So we did all that. I'll move forward because I know we're getting to the end of time. But the point is to reduce activation of the stress response. And with this intervention, this patient's growth rate went from 2.3 centimeters per year to over 7 centimeters per year in the 18-month treatment period. And her 9-month-old brother went from having 4 ear infections and 2 pneumonias in the previous year of life to having no more ear infections and many fewer URIs and no more pneumonias in the subsequent year. So we see that regulating the stress response is a means of both helping addressing the failure to thrive, which is a hormonal manifestation of the toxic stress response, and for her brother, the other patient, the immunologic response. So I will say, we can do this, right? And an important piece is you don't need to boil the ocean. You just need to play your position. And a big part of the work that we did also in California was setting up the environment to facilitate and pay for screening, early detection, and evidence-based intervention. And I can answer more questions about that during the Q&A. Thank you so much for your time and attention.
Thank you, Dr. Harris. I'm Hausen Cheong, and we intentionally reserved half of the talk for our more interactive Q&A section with our special guest, Dr. Harris. We have one in the chat. Can you comment on exposure to smartphones at a young age, social media using the context of these?
I have not seen clear evidence about the association between smartphones and the toxic stress response. What I can say is I actually worked with the former U.S. Surgeon General, Dr. Vivek Murthy, on this topic because we actually were looking at the rise of youth suicide in the U.S. and the trend began. There was a specific, a clear change in the curve in 2006, which was the release of the iPhone. It was really fascinating to see, and so we certainly are concerned about the association, particularly with online bullying and cyberbullying and with devices as a vehicle for harm. But I don't have a clear conclusion from the evidence yet.
Thank you. Another question is, will slides be available afterwards?
Yes, happy to make the slides available.
Okay, very good.
Yeah.
Can you assess and refer to services that are there always appropriate services available?
That's such a great question. So, when we're talking about screening for ACEs, and as we launched the ACEs Aware initiative in California, where we were in which we've trained 40,000 clinicians since 2020 on ACE screening and response. One of the things that happens when you put a line in the sand to say, we're going to, as a state, we're going to reimburse for ACE screening. As a clinic, we're going to screen for ACEs. Step one is not the screening. Step one is, what is your response network and your response infrastructure, right? And it kind of forces us to clarify what our response infrastructure is going to be. And the tricky part about it is we see that some folks are, that's a reason for them not to screen, like, oh, we don't want to screen because we don't have a response infrastructure. I think the challenge with that is that it leaves patients without the resources that they need, right? And so one of the interesting things that has happened in California is that as we put a stake in the sand saying we are going to do this, we're going to do early detection and early intervention, we actually invested in capacity building around response infrastructure. And one of the things that we did was we actually said that kids are eligible for wraparound services through Medicaid based on risk rather than based on harm. So rather than folks having to have a mental health diagnosis to get access to care, a child in California who has 4 or more ACEs can get access to enhanced care management, which is our wraparound services, simply based on their ACE score, right? So that allows us to use the science and the physiology to say, if we know kids with 4 or more ACEs are at high risk, we can actually intervene early when we can take advantage of neuroplasticity to get better outcomes and prevent harm. That's a long way of answering to say, if a child is eligible and they actually don't have mental health symptomatology, that actually means that they can get access, they can receive care from a community health worker or a promotora. They don't necessarily need to see a licensed mental health provider. And so what this is beginning to allow us to do now is innovate a little bit and use the science to be able to broaden the tent of who can be part of the solution, right? And so, because we know there aren't enough therapists in the world for everyone to get the level of care that is required. So how do we use the science to think about, can we go upstream? Can we identify who's at high risk? Can we intervene earlier so that the intervention needs to be less intensive and is more likely to be effective, right? So this is part of problem solving. I see a question here. On the ACEs Aware website, there is a clinical tool that was developed by my team at the Baby Child Health Center that we used all the time. And what it was kind of what you saw me explain in terms of the patient education. So it was some patient education about toxic stress. And then it also, we would also do a very brief kind of assessment of strength. So you'd have the interventions, and we would say, essentially there was a form, and the form is available on the ACEs Aware website under provider resources, where you could say, okay, which of these do you want to start with, right? There's sleep, exercise, nutrition, mindfulness, mental health. And how about, for my adolescents, it was like, okay, how about we download a free mindfulness app on your phone, and you're going to start doing, 10 minutes a day, mindfulness intervention, or 5 minutes a day, right? And you love playing basketball, and we would write it down on the form and then say, come back and see me in a month. We're going to see how you're doing, and we're going to continue to follow up and build, because you don't have to cure the whole problem in one visit, right? You can offer these resources, and there are a tremendous number of resources on the ACEs Aware website. What I find is, when you're talking about resistance, I think oftentimes you get the greatest patient buy-in when our interventions are effective at targeting are effective. Let me just put it that way. So over and over again as a clinician, I had kids, and I was in a very low-income, underserved neighborhood where violence was the leading cause of early mortality for that neighborhood. And a lot of kids came in to see me, and they would be on 5 different medications. So they were on Ritalin, and another medication would be added, and then that wouldn't work well, so they might be on an antipsychotic. I had a couple of patients on Seroquel, right? So we have and their behavior still is not that great, right? So it turns out, and I didn't show the slide on this, but this is why understanding what you're treating makes a difference, because the functioning of the prefrontal cortex works in an inverted U. If you have not enough catecholamines, right, not enough stress hormones, you're distracted, disorganized, and you have poor executive functioning. That's why Ritalin is the #1 treatment for ADHD. So when you add a stimulant, you have improved executive functioning. But if you have way too much stimulants or way too much catecholamines, you're back to being distracted, disorganized, forgetful, and impulsive, right? And in that case, for a provider who is treating a patient with ADHD symptoms, but they haven't done an ACE screen, so they don't know, are you on this side of the inverted U or are you on this side of the inverted U? If my patient has 0 ACEs, I would be more likely to start them on a stimulant like Ritalin or Adderall. If my patient has 5 or 6 or 7 ACEs, like most of my patients with a diagnosis of ADHD when they were coming to me had, I would be more likely to start them on guanfacine. Well, working in partnership with we had a consulting psychiatrist. So she would be more likely to start them on guanfacine, which was originally developed as a blood pressure lowering medication. It specifically regulates the stress response. And in addition to supporting the family to reduce the dose of adversity that the child is exposed to, we also make sure that when we write our medications, right, we're not adding stimulants to a prefrontal cortex that's bathed in stress hormones, that we're actually we know what we're treating, right? Because if someone has, if you're writing cough medicine for someone with TB, they're never going to get better, right? So we got to know, is this a cold, or is it TB, or is it lung cancer? Those are 3 different treatments. And so for a lot of patients, and so what we found in our clinical setting is that even though the family has been told, I'm going to say 95% of our families, what they found was huge relief. Because when we switch the kid off of 4 medications onto 1 medication, and he goes from failing to being on the honor roll, right, then they see the effectiveness. And I had a lot of patients bringing us gifts and making us cookies, and oh my God, thank you, because, and we feel good because we're more effective in our clinical treatment. I mean, I think you probably already know that I'm a huge believer in preventive mental health. In my mind, the analogy that I often use, and forgive me if I said this already, but it's really like the analogy that I use is with breast cancer, right? So when we made kids eligible for wraparound services based on risk instead of based on harm, for most of the United States, in order to get access to mental health services, you have to have a diagnosis, right? You have to be so harmed that you're symptomatic, right? So if we did that for when we take something like breast cancer, it would be like saying, in order to get access to breast cancer treatment, you have to have lost 20 pounds, night sweats, big lump, bone pain, right? And it's like, surprise, surprise, everyone who we detect is stage 4. The 5-year survival for stage 4 breast cancer is 32%. The 5-year survival for stage 1 breast cancer is greater than 99%. So if we want to improve our outcomes, one of the most important things that we can do, right, which the evidence is this is where there's clear evidence. If there's one thing that's unequivocal, it's that early detection and early intervention improves outcomes. So I absolutely agree with you. And that is why we changed our Medicaid policy in California to say that kids can get access to care on the basis of their ACE score, and they don't need to have any other qualifying diagnosis, right? In order for us to be able to do routine screening in primary care and intervention, one has to be, access to those services. But you heard me mention that we were working in partnership with a consulting psychiatrist who helped us be able to do this work. I do think that the more that we can do that earlier detection and leverage our workforce in ways that are smarter, right? I think that's how we drive to population-based improved outcomes.
How can ACE services be implemented in an acute adult inpatient psychiatric unit?
So I'm not a mental health professional, and I see that there are some excellent mental health professionals in the room, so I will defer to you. I think one of the pieces that is really important to recognize is that I think the way that it can be included in the acute inpatient setting is to recognize the role of a dysregulated stress response as part of an underlying driver of mental health presentation. So, for example, there was a recent study that showed that patients with 4 or more ACEs were 50% as likely to achieve remission with SSRIs for depression, right? So 50% as compared to patients with 0 ACEs. And with that, I liken the toxic stress response almost like HIV, right? If a patient comes in and they have pneumocystis and you give the treatment for pneumocystis, right? If you don't treat the HIV, that patient is less likely to get better, right? They're much less likely to have a good outcome. And for many patients who are presenting with mental health symptomatology, but also with diabetes or heart disease, if it's occurring in the setting of a dysregulated stress response, we need to treat both the dysregulated stress response and the comorbid condition. And so that's a piece that I would add.
Thank you. Dr. Cheong.
Over a quarter of California kids on Medicaid have been screened for ACEs. And the way that health policy works is we specifically targeted reimbursing for ACE screening in Medicaid first. Reason being, when a state pays for something through Medicaid, state leaders can then require private payers to do that. And that's what happened in California. In 2019, I guess, was when we implemented the ACEs Aware. 2020, we implemented the ACEs Aware initiative and then built the training infrastructure around that. And in 2021, the California legislature passed the ACEs Equity Act and required private insurers to meet the same standard that Medicaid did, which is a very common thing. And so now private payers in California are required to cover ACE screening as well.
Thank you.
This example that I gave with that 2-year, 9-month-old was failing to thrive and her 9-month brother. In that case, actually, and it's really important, this is why treatment of toxic stress is as important in adults as it is for kids, right? Because the 2.5-year-old had 7 ACEs, her mom had a lot of ACEs, her dad had a lot of ACEs. Whole family, right, was dealing with a dysregulated stress physiology. In that particular case, our social worker ended up filing a restraining order against the dad, which, by the way, I did the ACE screen, I saw the number. I still don't know which of those 7 ACEs that patient experienced, but I did know that I had enough information to be able to screen that patient in my primary care practice and also see the other 20 patients on my panel for the day, right? And then through our social work, was able to get further information. We referred to child-parent psychotherapy. In that case, as part of the court proceeding, I ended up writing a letter to the court about that the child had a toxic stress physiology. The court ended up mandating that the dad do, after the mom did child-parent psychotherapy and we got a better outcome, the next round was with the dad, and the dad had to work on his trauma history and healing as kind of part of that process. So it was actually, when we incorporated, we see the dad as the bear, but you also recognize that that's just intergenerational transmission right there, and it is really treatment of all the parties involved that are necessary to break that intergenerational cycle. And that dad did end up saying to his daughter, I know that daddy was really scary and really hurtful, and I'm really sorry, as part of a therapeutic process. So I'm not saying like it's all sunshine and roses and puppies, but when we really deeply understand this in a deep way, we start to recognize that the whole ecosystem is what needs to change.
And that we're getting close to time. I'm going to take this web question here. It's just moved. Are there any known resources, training, or treatment modalities for mental health providers that focus specifically on ACEs, or are the preferred intervention trauma-informed care models? And such as over here, and then one of the audience members put a hyperlink to training.aceaware.org.
Yes. So through the ACEs Aware initiative has many hours of professional development and training that's like CME eligible and for folks to get their educational units, and specifically has different modules for mental health providers, for providers working in different communities, for providers working with indigenous communities, for providers so there's a lot of tailored educational materials. There are also other resources for folks working with kids, the National Child Traumatic Stress Network. I know that SAMHSA has some training. So there are kind of increasing numbers of trainings for trauma-informed systems of care for both mental health providers and primary care providers.
Thank you. And then getting down to 2 minutes. Since there are limited mental health resources in Hawaii and often long wait times to see providers, what would you suggest for PCPs that end up screening for their patients for ACEs and obtaining a positive screen in terms of resources that families can utilize in form of self-help that are not readily available?
So at UCLA, they did a clinical pilot around using 211. Are you all familiar with 211? Once a clinic makes the decision to start screening, and then again, before even screening, the most important piece is what are we going to do with these outcomes? Part of it has to do with coordinating with our networks of care, community-based organizations that can be a referral source, and looking at to provide the whole suite of evidence-based buffering interventions. The UCLA did a pilot where they did an online mindfulness intervention for kids who experienced, who had high ACEs and who were also scored high on the PHQ-9, so the depression screen, and they found reduction in depression symptomatology with that online, so that wasn't even like a hands-on. But again, it's when we get more precise on what we're targeting, when we say, we recognize these patients have symptoms of depression, but there's an underlying disrupted stress physiology, and so we're going to, while they're on the wait list to get access to a mental health provider, we're going to target regulating that stress physiology, and we're starting to see improvements in outcomes when we take that targeted approach.
Very good. We actually have more questions than we have time for. Dr. Harris, thank you so much for joining us.